Good evening, everyone. I'm David Meltzer. I'm the faculty director of the Health Lab, and on behalf of the Health Lab, the Mansueto Institute, and the Institute of Politics, all of which are housed at the University of Chicago, I'm so pleased to welcome you to tonight's event. This is the first Urban Innovations event that we've held, and we're excited to have you here. Let me first tell you a little bit about the Health Lab. At the Health Lab, what we seek to do is to partner with cities and the organizations that care for the city's residents, which we hope is every organization, to try to unlock the power of science and data to inform policy and ultimately to improve human lives. We work with our partners to identify and try to rigorously evaluate policies and programs that can have the greatest potential to address some of our community's greatest challenges. Tonight, we're honored to have three truly extraordinary individuals here to discuss some of the unique challenges facing incarcerated women, and in particular, mothers. We'll hear tonight about some of the innovative solutions taking place in New York and here in Chicago. Nationally, there appears to be a shift taking place within jails and prisons to try to better design reentry programs to address some of the critical challenges these women face. My hope is that at the labs and the Health Lab in particular, we can work with our partners to generate, produce, and share findings on what's effective and how to make these programs more effective. First, I'd like to introduce our event moderator, Alexa James. Since 2013, Alexa has served as the executive director of NAMI Chicago. She's a licensed clinical social worker, and she's devoted her professional life to serving people living with mental illness, as well as those impacted by poverty and trauma. She earned her master's degree in social work from Loyola University and in child development from the Erickson Institute. Ladies and gentlemen, please welcome Alexa James.
Good evening, everyone. I'm glad we're all cozy in here. It's kind of crummy out there, although the sky is not looking as rainy anymore. Thank you so much for the introduction. Welcome, and great to see so many of you, friends, new faces as well. This is going to be a really wonderful discussion, so I will be brief because I know everyone is here to see these two amazing women who are going to speak about their work today. I do want to thank you of Chicago Health Lab, Mansueto Institute, and the Chicago Institute of Politics for organizing what I hope to be an important and engaging conversation. So I'm Alexa James, as was mentioned, and I run an organization called NAMI Chicago. And at the National Alliance on Mental Illness, we support people who are impacted by mental illness, which is arguably all of us. And we do a lot of work with emergency responders. We do a lot of work in the community to raise awareness and decrease stigma. And I'm super excited about this conversation. I am going to introduce the speakers shortly, but first I want to set the stage a little bit about tonight's topic. Tonight's topic is about reshaping services and supports for women leaving the criminal justice system, given the unique circumstances and the issues they face. So like I mentioned, we're doing a lot of work with first responders. We know that we have to train people who are interfacing with folks who are living with serious mental illnesses, because so frequently these individuals are criminalized because of their mental health issue, right? Between 2,000 and 2,500 people a day are at Cook County Jail, and they're there because of their mental health condition. So we know that law enforcement need to be trained, and we do this work at NAMI with our partners at CPD. We train officers to learn how to de-escalate situations, understand red flags. Also, we do this work with call takers and fire department, right? And so we're trying to divert individuals who are put in contact with law enforcement away from the justice system, but they still end up there all the time. They fall through the cracks and end up in our jails and prisons. So we could spend an entire evening, an entire week, years even, talking about this issue that affects us both nationally and at a hyper-local level. This issue about the intersection of policing and mental illness. But we are not going to do that tonight. Today, we're going to instead focus on the systems and the programs in place for those individuals experiencing mental health issues who do end up in the jails. In particular, we will focus on women and mothers. Without further ado, I'd like to introduce two women who through their different careers have witnessed the toll that the criminal justice system can have on mothers and children. They've also spent a significant time advocating for and working to redesign incarceration and reentry programs to thoughtfully and strategically address gender differences, which we all know there are, mental illness, and parenting. I also want to mention quickly that there are index cards under your seat. Maybe some of you have already picked them up. There's going to be an opportunity to do Q&A at the end, so if you have questions as they come up, please do fill them out, and then our friends who are raising their hands will walk around and collect them. So let's first start with Dr. Jones Tapia. Dr. Jones Tapia is the former executive director of the Cook County Department of Corrections. Prior to assuming the role in 2015, Dr. Jones Tapia was the first assistant executive director of the Cook County Sheriff's Office, where she oversaw mental health strategy at the Cook County Jail. It's a big job. On any given day, Cook County Jail, like I mentioned earlier, houses between 2,000 and 2,500 inmates with mental illness. And in this effort to slow the revolving door of folks cycling in and out of the system, she developed the Mental Health Transition Center, which is fabulous. This builds a support system to help people who are re-entering their communities. Prior to joining the Sheriff's Office, Dr. Jones Tapia served as the chief psychologist at Cermak Health Services, the on-site medical and mental health provider at Cook County Department of Corrections, where she developed and chaired numerous mental health programs and committees and advised the Cook County Department of Corrections on mental health-related issues. Please welcome am I doing everybody at the same time? Dr. Jones Tapia. I'm not following the run of show. People who know me know that I'm going off script. Sorry about that. And the First Lady of New York City, Lady McCray. In addition, we are so excited that she's here. Ms. McCray has redefined the role of First Lady, managing a robust portfolio to advance an ambitious agenda in support of all New Yorkers. Ms. McCray created Thrive NYC. There's some information that you have on your seats about that as well. The most comprehensive mental health plan of any city or state in the nation. And she is recognized nationally as a powerful champion for mental health reform. Additionally, she spearheads the city's Thrive Coalition of Mayors with representation from over 200 cities from all 50 states, advocating for a more integrated and better funded behavioral health system. Amen. As chair of the Mayor's Fund to Advance New York City, Ms. McCray brings together government, philanthropy, and private sector to work on some of the most pressing issues of our time, including mental health, youth employment, and immigration. Ms. McCray has embarked on an ambitious $6 million initiative to better meet the needs of incarcerated women and their families, a program which could become a national model, we hope, for gender and family responsive incarceration efforts. Please welcome Ms. McCray. All right. Can we start with you, Ms. McCray? We're all very excited to hear from you about what are the current challenges facing women who are re-entering the system in New York City, and what programs have you implemented to change this, and how did you come about understanding this issue?
Goodness, well, there are many, exactly. Women have significant needs, unique and significant needs when it comes to being incarcerated. And you know, we've come to this realization over time. It wasn't like all in one moment, but when you look at the statistics, we recognize that most of the women who are incarcerated have experienced significant trauma. Violence through domestic violence, other types of violence. They've been abused, sexual abuse. Many of the women, most of the women have some type of mental illness or have struggled with addiction. 74% of the time, that's really high as compared to maybe 42% of the general population. Many of the women, again, probably most of the women have experienced employment or housing insecurity. All of them at some time in their life have struggled with that. And then most of them are mothers or caretakers of other people, roughly 3/4 of them. So when you combine all of those things, and you realize that you're not just taking care of an individual, you're really taking care of a family. That once they become incarcerated, that all of their individual needs have to be addressed, but the needs of their family have to be addressed as well. So we've addressed this with counseling, counseling inside, counseling outside, by providing the transitional services, the housing, for example, employment. And what we have found is that we have to use the same providers inside as outside, so that there's a coordination of effort, that no one falls between the cracks, so that we make sure that there's no gap between the care that they're getting inside and the care they're getting outside. And then, of course, we have to provide care for the family as well. These women have children, and if they're not connected to their families, if they're not maintaining that bond between mother and child, it has long-lasting consequences for those children. Those children are more likely to become incarcerated themselves. They have trouble in school, trouble outside of school. We're just creating more problems. We're creating the problems. So we're trying to disrupt the generational cycle of incarceration by, again, dealing with the whole family.
So you said that you're providing counseling services, mental health services inside as well as outside, and using the same providers, which is so interesting, right? Because we talk about continuity of care as being so critical. And we all know that stigma is one of the biggest barriers to mental health treatment. So but we also know that accessibility is a huge barrier. Can I get to this appointment? Do I need, to go 12 buses? Do I have to cross communities that make me feel unsafe? So can you tell us a little bit about, have women been engaged in this, or has there been levels of stigma that you've had to combat?
Oh, stigma is everywhere. The stigma is significant, and that is, I think, probably our number one challenge is dealing with that. But women are motivated to connect to their families. They don't get as many visitors as the men. So, the men will get, women with their children. The women get so few visitors, and that is discouraging to them. So one of the things that we've done, which has helped lower the level of violence, is make sure that their children can come visit them. They can have longer visits. They have visits with people who are in civilian clothing, in a space that is designed to be child-friendly, so that they can actually have a good time, a fun time that is not intimidating to them. And this really helps motivate them to wanting to be good parents, better parents, and take up the opportunity to get counseling. And once a woman is incarcerated, the first thing they do is get a reentry plan, right? A reentry counselor to help them navigate their stay while they're there, and then their stay once they're out. We find that lowers the recidivism and makes for a more successful transition. You have to start from day one.
It's interesting because that's the model of inpatient hospitalization for psych, right? You start discharge planning when somebody gets admitted. It's a similar model. Dr. Jones Tapia, tell us a little bit about your strategy for supporting people who had mental health and substance use needs at Cook County.
Sure. I was in speaking with First Lady McCray earlier today. I was letting her know how in awe I was of New York. What we've been able to do at the jail, they've been able to do at a much larger level for the entire city. So we aspire to be like New York in that regard. Now, for the jail, mental illness is real. And when we talk about our female population, I think it's important to draw the landscape of what those numbers look like. Fortunately for us at the jail, since 2013, we've seen a decrease in the number of women coming into the Cook County Jail. So to give you an idea of those numbers, in the year of 2013, we had about 10,000 women that were admitted into the jail. Fast forward to 2017, we had about 7,000 women admitted into the jail for that entire year. So on any given days, and currently we have about 400 women that are housed at the jail, which is much lower lower than what we were contending with years ago. And so I speak about the numbers because that helps us to realize the power of advocacy around diversion. And that was where the sheriff really wanted to start, advocacy around diversion. Let's get as many people out of the jail that don't belong there as we possibly can, and those efforts are continuing. Secondly, it was important for us to focus on training. You know, correctional staff, law enforcement, they were never meant to be first responders to individuals with mental illness, but we knew due to the complexities of our system, we were getting more and more individuals in our custody with mental illness. And we know what happened from 2009 to 2012 in Illinois with significant budget cuts. But around the training, we have officers that are trained in gender responsiveness. And we try to have as many female staff working with female inmates as possible to reduce repeat trauma. We know that women coming in, men too, but more so women, as First Lady said, are coming in with complex traumas. Thirdly, we wanted to invite quality programming into the institution. And because, again, our numbers were dwindling for the number of women, we were able to really invoke the help of the community. So I see many of our community partners in the room, like Task and West Care and Thresholds. So we were able, in Heartland, thank you. We were able to get the community into the jail to begin offering services to not just the women, but to also the men. And that made a difference, as First Lady alluded to, having the same provider working with them in the jail as those that are going to be working with them in the community. So we partner with the Health and Hospital System, which is our on-site medical provider, and the community partners. And then finally, and most importantly, it was the reconnection with family. We know with women, family is important, and many of the women coming into custody have been the primary caretaker of the family, and so you want to maintain those family connections. So our female population, it was important for the sheriff to have contact visits between mothers and their children so that they can maintain the connection, or at least begin to form them. Some of them had their babies while they were in our custody. And so those were the primary areas, and hope, for now, I left the jail March 28th of this year, and so I'm still connected, though, to the jail. Even though I'm in a different place, I'm still going to continue to advocate for all of the things that I know the sheriff is hoping to accomplish, and one of them is around release planning for female inmates. We've started the release planning process. We have a good system in place at the jail, but now our next step is to figure out what they need for an ongoing basis in the community.
First Lady, do you see the population of women declining as well in your?
Yes, we do. The overall population has decreased by 25%, but the women's population has decreased by 29% since 2014. So we're very excited about that. We have an average daily number of about 580 women who are at Rikers, and we see that number going down. And we envision that we will have even fewer in the months to come, given the new plans that we have in place.
So what do we attribute that to besides diversion? Is there any other trends that you're seeing? Because we see here in the juvenile system actually more female young people coming through our system. So it's interesting that it's not that in the adult justice population.
Well, I know particularly in Chicago, adolescents, we have a higher rate of violence among our adolescents. So it makes sense to me that we're seeing more female adolescents coming into the juvenile justice system. Whereas with the adult population, I think it really speaks to not only advocacy, but also the sensitivity around the disruption of family when you're incarcerating women for more nonviolent charges. As the female population started to decline, thanks to our wonderful research team at the sheriff's office, we were able to see that the women coming in were coming in with more violent charges. So that speaks to the fact that we were getting people that actually belonged in the criminal justice system.
It's interesting.
Yeah, we've also employed, we're not incarcerating women for low-level offenses. We have other forms like supervised release, transitional housing, where we are we're keeping them before trial instead of putting them in jails. If they have a charge that would involve them being there for less than 30 days, we don't want them there. We try and work with them in some other way, and we have an alternative to incarceration plan, and we work with them. Their cases are all different. We give them what they need so that they can stay out of jail, tend to their families, and work.
Okay, so everyone here in our Illinois crew is wondering, who is paying for that? How is it funded? Is it sustainable? Tell us all the secrets.
Well, I mean, New York City is paying for many of the programs, but we have some wonderful community-based organizations that we work with that do a lot of the work, and I think that they've always been around and they've always provided excellent services. What we're doing differently now is that we're actually working to coordinate the services. So we have many of the same services, but they're improved by the fact that we have a coordination of effort. And that gives us much more bang for our buck, and helps, because it helps them to have better outcomes. It helps us not lose clients because they've dropped out of the programs. So I think it's a better use of the funding that we have, that we are all working together in this way.
One of the biggest heartbreaks that I've heard, not one time, not twice, but really chronically, is this. This is what we hear at NAMI all the time. I hope my loved one gets arrested so they can get treatment. And then that's the family. And then we hear the individual, I have to break a window. I have to do something so I can get locked up again, so I can get treatment, so I can get my meds. So for us, it's if there's richness happening, and there's richness happening without, but we have no capacity. I mean, talk a little bit, Dr. Jones Tapia, about those challenges and what conversations are happening around capacity building from those community providers.
Absolutely. So now that I am working more intricately in the community, I see that there is the possibility of capacity as long as we have our financial backers at the table as well. I mean, we know, again, Illinois cut $113 million from the mental health budget 2009 to 2012, and that significantly impacted the community providers. But I believe that we have significant resources that are available. It's a matter of making sure the resources are matching the demand, and a lot of that is related to stigma. And so I am less quick to say that there isn't capacity around mental health services. We all know that we need more help with psychiatric services. So I'm hoping that hospitals will become more engaged, and I'm encouraged by what I'm seeing happening in the community, particularly with hospitals, area hospitals. And again, to speak to the value of our community partners, it's important to not only have them to be available for individuals when they leave the jail, but to what the First Lady said and what's happening in Cook County, but again, also having them for the individuals while they're in custody, so you can reduce that stigma and they're more likely to follow up with services post-release. Those things are important. I am going to be encouraged that with the new news about our mental health initiatives that are happening with our Medicaid, that we'll begin to see more resources available in the community.
You talk about housing, right? That's kind of what we're missing here.
Yes.
Because when you get released to the streets, I mean, housing is healthcare. So was there a pushback? Was that already in, was housing already available and in abundance? I mean, can you talk a little bit about that? And then, before we get to Q&A, we'd love to talk a little bit about the evaluation process. But if you could talk to us about how do you have housing for people while they're awaiting trial?
Housing is a huge problem. It's expensive to live in New York for anyone, and so that is, I think, a major hurdle. We have had success with transitional housing for women. We have housing for them in every borough, so that there is a place for them to stay before going to trial. But we don't have that for men. So we're seeing greater success for the women because they do have this housing, and if you have housing, you have a place where you can you know, go to counseling, you can take your medication, you can do so many things if you have a place to stay. If you don't have that, it just, you know, if you're in a shelter situation, it's just not as good. So we're struggling with that when it comes to the male population, but it is clearly the missing element in so much of what cities are able to do.
Before we move on, I just want to give you an opportunity if you wanted to say anything about housing.
It's a problem.
It's a problem.
We need it. Help.
Yeah, help, right. So how, we'll go back to you. How are you evaluating the efficacy of your program?
Well, we're evaluating everything that we do. We know the data is really important, that we want to make sure that other people can duplicate what we're doing. We want to be able to improve on what we're doing, and the only way we can do that if we're not assessing and evaluating. So research is an important part of all of our programs. I would add, though, that it is one of the challenges, and we need help with this. We need new ways to measure the outcomes of disrupting intergenerational incarceration. That's a tough one. That takes time. And how do you do it exactly? We're looking for ideas on how to do that and how to do it better.
And are you seeing recidivism change since?
Yes, recidivism is definitely down a lot.
Congratulations. That's big news. That's the goal. And Dr. Jones Tapia?
Yes, so we have great partners, particularly those in the room. We are partnering with the University of Chicago Urban Lab to study some of the initiatives that we're starting. And one that we are proud to talk about a little bit today is we're focused on not just the discharge planning, again, that occurs at the jail, but the ongoing release planning that is occurring in the community. And so right now, working with the urban labs, we're starting a study with the women in Cook County Jail to determine what those needs really are and to determine what they could benefit from. And we really got this idea through our partnership with Heartland Alliance and with Task, because they have developed a supportive release center for men. And so it was really eye-opening to see the changes that the men were going through by having the ongoing supports in the community. And so we want to do something similar for women, though we know that women are going to have different needs. So we're going to assess what those needs are, put a compilation of ideas together, and then reach out to our community partners to talk about how we can develop something strategic for women so that we can have some of the greater results for women getting out of the jail and staying out of the jail.
That's the goal. So that's what you're doing now, right? I mean, we're kind of, where everyone's wondering, where is Nika? What's she doing now? So it sounds like you have a pretty big plate of work to do.
That's part of what I'm doing now.
Can you share with us what else you're working on before we open it up for Q&A?
Sure. So right now I'm also a senior fellow with the University of Chicago Institute of Politics. My focus has been on trauma within the criminal justice system, not just the inmates, but also the staff, law enforcement. And so we're really having some insightful conversations about how we can better impact not just the inmates, but the staff that are working in law enforcement.
So First Lady, while I'm waiting for my cards here, what's your headline in 10 years in New York City about incarceration? What's the dream?
Oh my goodness. Oh.
I gave you no time to think about that.
You just popped that one out. Okay, my dream headline: incarceration banned, eliminated. I don't think it should even exist, actually. So that would be my dream headline.
There you go. That's good. What's your dream headline? 10 years.
In 10 years. I don't think I can say incarceration banned with the escalating violence that we have in Chicago, but I can say closure of more incarceration facilities and opening of more treatment facilities in the community.
Right. I think we would all like to see the reallocation of costs, that's for sure. We know that we're using the most expensive interventions far too often, right?
Amen.
Okay, so this is right. So we're going to kind of get in a little bit more in depth about what your reentry services look like. So can you each take a moment? We'll start with you first, lady. Like, what does a reentry service look like? What does a day look like that would be different from a typical stay in a jail? And what does it look like once they leave?
Well, the reentry services begin on day one, as I said, and they're tailored to the individual. So it's hard. There's no typical plan. For example, if you take a woman who's suffering from mental illness, maybe has struggled with addiction, she's going to have probably counseling, some kind of therapy several times a week. She's going to have group therapy. She might have psychopharmacology. She might have, we have these observation units where women who have more serious mental illness can be observed and receive some different kinds of therapy there. And then, of course, because reentry, we're planning for reentry, all the time she's there, she will have probably met with an employment counselor. If she has children, her children are maybe getting in-home therapy at the same time. The services depend on the needs of the individual and the family. We try and make sure that there are wraparound services, that there are warm handoffs between providers. So it's totally dependent on what the need is. Housing, if that's a need, we'll work with her on that, so that there is less of a chance of recidivism. I will say that we are seeing fewer women present at Rikers with mental illness, which I think is by 23% less, which is, that's huge. So I think that we are being successful in making sure that women are getting the services they need while they're there, so that at the very, very least, there's a great deal of improvement in how they are able to maintain a stable life.
So quickly, like Rikers, we have our release planning that starts on day one. We have everyone coming into the jail receives an assessment with a follow-up treatment plan. And if they leave on day two, then they at least have their follow-up treatment plan in hand. We have close ties with the Health and Human Services, so that we have ongoing responsibility for the children by introducing them again into the jail setting, so that they can have the ongoing communication and reunification with their mother. And then we also have a discharge planning process by which everyone that has been treated for mental illness and substance use in the jail is released through one area of the jail. They meet with a community provider before they leave, and then that community provider will set them up for an appointment but prior to their release, and then follow up with them upon release. And then the sheriff's office was fortunate enough to have a van donated, so our correctional staff will provide transportation, even for individuals that have been released to the community, because we know the importance of transportation to jobs and things like that. And I think what I'm proud of are the job training programs that we developed within the jail. Most jails don't have job training programs. Those occur typically in prisons, but it was important for us to have people leaving our custody with skills.
Thank you. I love this question because I think that we all in this room, and probably agree here too, the power of peer support. So can you talk a little bit, either of you can take this, or if you're both doing it, please do share, the role that women can play in the community to provide peer support to each other who have lived experience of incarceration and mental illness?
Sure. So, women are much more relational than men, and so the power of peer support is incredible. I do believe that through our research that we're doing with the labs, we're going to find that many women will be a support system to each other, not just in the jail, but in the community, and that will be a valuable piece of the release plan. And it's important to not just discuss women in the relational aspect, but also to recognize that because because of that, women see their self-worth a lot through the relationships. And so when we can have positive relationships, that will give us a better opportunity for improvements and less likelihood of returning into the criminal justice system.
Okay, great. So, what is the role? I'm sorry, not mic'd. Is the role of having being a Medicaid expanded state, has it been harmful? Has it been hurtful? This idea of care coordination, this idea of maybe losing your benefits when you're incarcerated and it slowly hits back. Does that hinder the opportunity to connect with a mental health provider once folks leave incarceration? And I don't know if you have those similar challenges where people lose their benefits while they're incarcerated in New York City like we do here.
Through working with our community partners, it was great to be able to advocate for a suspension of services instead of Medicaid services being turned off. And so it has helped us, in my opinion, being an Affordable Care Act state and a Medicaid expansion state, because once we begin to see those dollars attached to individuals, we begin to have more community partners that were willing to volunteer to come into the jail and offer services, which was helpful to us, because as those numbers started to increase, of course, capacity increased in the jail, we didn't have the staffing or the budget to meet that demand. So to have community partner involvement was helpful. And then to hear the inmate stories of how they would have to wait for months for an appointment in the community, to now that being dwindled down to a few weeks since the Medicaid services are just suspended. And then we have our navigators that are there at the jail to help them with the application process has been helpful.
Yeah, we have a similar situation in that we have these suspension so that there isn't that interruption. So everything goes much more smoothly and quickly once they re-enter the community. It makes a huge difference when you're able to work closely with the partners and they know that this is going to happen. It really has speeded up everything, and it has improved the quality of outcomes.
I have to say, too, I wish we would have a similar process for public aid benefits. Food security is a big problem, and when we have the cancellation of services, we see women and men, but women in particular, because they're the caregivers, struggling to meet the demands of the family around food security.
Well, and so we think, too, how scary it would be to think that these programs could go away, right? What a detrimental effect it would have on all of this good work that's being done that's so clearly reliant on Medicaid and those programs.
It'd be very expensive.
Well, right, and it's kind of like where we started. Why folks are entering the justice system in the first place who have mental health conditions. So there's a question here that, there are many people in this room who are mental health providers, housing experts, et cetera. What is the best way for them to connect with people who are leaving the jail and vice versa? How do you form collaborative? And can you talk a little bit maybe about Thrive NYC and how that plays a role in connecting with so many different partners?
Okay, I don't work directly with Rikers, but I can talk about Thrive. And what we have, Thrive is our public health approach to mental illness and addiction and substance misuse. It's a series of programs with a core program called NYC Well, where people can connect to mental health services. They can speak to, and this is for providers and individuals. So anyone can speak to a trained counselor or a peer counselor and get connected to a program, make an appointment with a provider, with a warm handoff. The counselor will stay on the line and even call back the next day or whenever the client wants to make sure the person got to that appointment, that the appointment was appropriate. We have many providers calling this line as well, because NYC Well, because these counselors now have an amazing resource of all the programs in the city. We never had this before. We've never had a real mental health care system in our country, and we're trying to build one in New York City by with Thrive, and NYC Well, I think, is the core. We have hundreds and hundreds of calls every day, more than 700 or 800, sometimes as many as 1,000. Providers rely on this as a resource, again, as well as individuals. And it's really making a difference in how people are able to know, like get a mental health crisis team, a mobile crisis team for adults or children, reach a peer counselor, somebody with lived experience. All kinds of information is there for anybody who needs it, and it's free. It's absolutely free. Anyone can connect to this resource for free.
I think that really speaks to the need to have a buddy or a partner or an agency that can help people negotiate the mental health system, because it is so complicated. And in fact, we really see that as a diversion tool, right? Because if folks can get help earlier, they're not going to get to the point where they are acutely ill, where either they're going to the hospital or they're going to lockup or they're going to jail. And I want to say too, because you mentioned earlier that we need more psychiatric care, and one of the questions here is, what does that mean? And I think we all want to be really clear that doesn't mean more hospital beds, that really means more community-based treatment, because in essence, hospitalization, although we need it, and it's crisis intervention and stabilization, is kind of another institutionalized method of dealing with people who are suffering from serious mental illness.
Right. Through Thrive, what we're doing is we're enlisting all of our community partners. For example, clergy members, we know that they're often the first responders for people. So we're working very closely with them. We have a clergy council. We've had 2 weekends of mental health with the faith communities. The first year we had 1,000. The second year we had 2,000. Mental Health Weekend is coming up again this year, May 18th, May 20th, and anybody can participate. We ask clergy members to devote part of their service, part of their sermon, to talking about mental illness and addiction. Having them get up there and talk to their congregations about this makes a huge difference. These are trusted members of the community, and it takes away the stigma of having that kind of conversation, and people feel more comfortable going to them. We're training 250,000 New Yorkers in mental health first aid, and many of our clergy members are now trained in that, and that helps them to be able to respond to those in their congregation who may need their help. We also provide an online resource for them, Thrive TLC, Thrive Learning Center, that they can access to they can access modules on psychosis or depression or anxiety, so they can build up their skill levels. We have many community partners. We think that of the people who are in our community-based organizations as being a huge resource, and with just a little bit of training and mental health first aid, psychoeducation, motivational interviewing, they can do so much to make sure that someone's first interaction with mental health services is not a police officer, right? Not a traumatic experience. By getting New Yorkers trained who are either with community-based organizations or clergy or wherever, by getting them this very basic level of training, they can do so much to make sure that the people are directed to appropriate care. And going forward, we're going to be emphasizing that family members are really the first responders. Family members always know what's going on, but they have to know that there is some place they can turn that will not be traumatic for themselves or for the family member or friend, that they can call this number, or they could go to a community organization and get help for the people that they love, the people that they care about. We're not there yet. People don't have all this information, but that's where we want to be. We want people to recognize that jails, our jails, our prisons, our emergency rooms, our shelters, that this is the result of untreated mental illness, untreated addiction. This does not have to be this way. If we act early, people can get the care that they need and be able to live a healthy, productive life.
I mean, exactly what you said. Yes. So we've run out of time, unfortunately. I know that now let's transition to dinner and getting into, we just scratched the surface. But I think in closing, one call to action, one thing that we can all do to get to where you just said.
Okay, I have 3. Okay. All right. One. Everyone can take mental health first aid. No matter where you live, there's some place you can connect to it. Take it. Encourage other people to take it. We don't grow up with this information, and unless we get other people to understand what we all know about basically like bleeding, what to do, we got to get people to know so they can address when people are having a panic attack or something. Second, Cities Thrive is an amazing coalition of cities. Call your mayor's office. I'm going to give you a number. Actually, it's the Department of Health. 312-747-9884. I'm going to say it one more time because I really want you to call and say, Chicago should be a member of Cities Thrive. It's free. We give free information and technical assistance, and we want you to join. The number is 312-747-9884. Can you all please call? I don't hear you. Will you all? Please. I've been working on ROM for a long time now. I want this to be it. My third ask is that you engage your houses of worship. Let them know that we're having this weekend of faith, weekend of mental health for the faith communities, and they can be involved. It's free. We provide a toolkit, talking points, resource center, online learning center. We give them everything that they need. We have conference calls with them. So all they have to do to sign up is call 646-430-0050. You will reach Teresa Doherty, who's the program manager for Faith and Community Partners. I'll give the number one more time. 646-430-0050. This is a wonderful weekend experience. It goes a long way to alleviate and eliminate stigma and get people talking about mental health. All right.
Very good, very good.
May I have 2 things?
You may.
Okay, thank you. Realizing that trauma is different than mental illness and having thoughtful conversations around both, not assuming that because someone has experienced trauma that they have a mental illness, and then engaging in conversations even in the household to increase awareness. I think the stigma that we've spoken about today can start to be broken if we start to have those thoughtful conversations in our inner circles.
All right, well, we have a lot to do. I think that we can send those phone numbers around too for the listserv about everybody who showed up today. So we will remind folks to call. So thank you so much for that information. And thank you both so much for sharing your wisdom and your time with us tonight.
Thank you.
Thank you.